Welcome guys to this discussion of polycythemia, its approach and management, Harrison based. Now we will discuss some of the MCQ and side by side its discussion so that the chapter gets complete from Harrison. Now coming to the first question, which of the following is correct regarding diagnosis of polycythemia? So before going to the question, what is polycythemia guys? Polycythemia is defined as the increase in the hemoglobin above the normal range, and it has been defined for the male and female different cutoff. So male, if hemoglobin value is more than 16.5 gram per dl, it is considered significant for polycythemia, and for female the value is considered to be 16 gram per dl. Similar to hemoglobin, hematocrit value has been also set up. For male it is more than 49% and for female it is more than 48%. Now you can see from this question clearly it is hemoglobin more than 16 gram per dl for female is correct regarding the diagnosis of polycythemia. Now, as you can see from the definition and the cutoff criteria, there is nothing clinical in it. Everything is based on the lab parameter value. So, if everything is based on the lab parameter value, most of the patient comes into the notice when they come in the OPD or to the clinician with a CBC report for completely different reason which shows such value. And so, most common presentation of polycythemia are usually asymptomatic in nature. Alright. So as you can see here, in a patient which comes to clinic, you can find for completely different reason he came and CBC was done, which shows hemoglobin to be 20.1 and PET cell volume very high, that is 57.5. So it doesn't matter what was the symptom of the patient, whether male or female. For with such high value, this person is having polycythemia. Now if I level just based on this report someone polycythemia, a question should come in mind whether this report is truly reflective of the condition, or it is false. So from here we come into the concept of relative versus absolute polycythemia. So remember, our blood component has two parts. One is red blood cell and other, apart from it we have the component of plasma. All right. Now polycythemia is something that is to do with the RBC component part, and if RBC increases, red blood cell increases, it is considered to be polycythemia. Now this report can be erroneous if plasma value is low. So if plasma is low in the patient for some different reason, then RBC will be apparently high, giving a false impression of polycythemia. When plasma is low, plasma can be low due to lot of causes, like for example dehydration. It can be due to dehydration, can be due to diarrhea. It can be due to concomitant use of diuretics, or a condition which leads to capillary leak, that is leakage of plasma into the other component of the body, giving rise to proliferation, serositis and ascites. And when is capillary leak seen? Capillary leak can be seen due to the drug, different diseases, and most commonly into the infectious diseases like tropical illness like dengue and chikungunya. All right. So here we come to the concept of relative versus absolute polycythemia. Next, you should also know the concept of erythrocytosis and polycythemia. Now, erythrocytosis and polycythemia, both terms can be used interchangeably, but to draw a distinction between them, erythrocytosis implies documentation of increased red cell mass. So it is documentation of increase of the red cell mass, whereas polycythemia is means increase in red cell. Okay, so here we know that this polycythemia can be detected from either of this hemoglobin and hematocrit, both of the values. Now coming to the next question, all of the following are causes of relative polycythemia except just discussed now. Relative polycythemia or spurious polycythemia is seen when there is decrease in the plasma volume. And when there is decrease in the plasma volume, when there is other causes leading to it, for example dehydration, there is dengue hemorrhagic fever or hemorrhage per se here as given in the option, or diuretic use, in such cases there will be relative polycythemia. So dehydration, there will be relative polycythemia, dengue hemorrhagic fever relative polycythemia. What is gas box syndrome? So it is relative erythrocytosis or polycythemia due to reduction of plasma volume, which is also associated with stress. All right. Now, actual red cell mass obviously remains same here, and erythrocytosis apparent due to the decrease in the plasma volume. Now, what happens in high altitude? In high altitude, there is hypoxia, which stimulates the erythropoietin, resulting into increase in erythropoiesis and polycythemia. Therefore, it is a true polycythemia, a type of a secondary polycythemia. So answer here is high altitude. Coming to the next question, gas box syndrome. We have just discussed now. Gas box syndrome is relative polycythemia or spurious polycythemia. Okay. So next question, polycythemia vera is typically associated. We know the value. We know the value for male and female both are different. For male, it is more than 49% hematocrit, and for female, it is more than 14%. So we know we can define polycythemia from hematocrit value as well as for hemoglobin. As you can see here in the patient, we have hemoglobin more than the cutoff value as well as hematocrit more than the cutoff value. The question should arise in your mind, which one to take as a choice for diagnosis, whether to hemoglobin. As a clinician, which one is a better marker, or the hematocrit to identify someone with polycythemia. Now remember, this CBC report, as it is analyzed by the machine, this automated machine that quantifies red cell parameter actually from the hemoglobin value. So it takes the hemoglobin concentration and calculates the hematocrit value, right? So hemoglobin is a better marker or better indices for diagnosis of polycythemia than hematocrit. Now, how is hematocrit calculated? Hematocrit is calculated by the formula RBC multiplied by MCB by 10. Okay. So this is the formula for calculation of hematocrit percentage. Okay. Now, what to do next to the patient? This patient was completely asymptomatic. So how to go further to approach the causes behind this polycythemia and how to manage this. This can be easily identified this Harrison chart, which beautifully shows the pathophysiology as well as the causes behind the different reason behind polycythemia. Okay. So as you can see, it is given in stepwise fashion. So what is the first step, guys? First step, when there is increase in hematocrit or hemoglobin, that is, this is coming to be a case of polycythemia, is to differentiate whether it is relative polycythemia or absolute polycythemia. How can be differentiated? And gold standard test for this differentiation is taking the patient with 51 chromium level RBC and to check the radioactivity after 2 hours. If the radioactivity is normal, the patient means the total RBC mass in this patient is normal and the patient is having relative erythrocytosis. Whereas if this radioactivity is elevated, that means red cell mass is increased and it is absolute erythrocytosis. Now, once you know that is absolute erythrocytosis, what is the next step? Next step involve checking for erythropoietin level. All right. Now, if this erythropoietin level is low, this is a case of polycythemia vera, and you need to confirm with the checking the mutation value. So, what are the mutations that you need to check? JAK2 is the most common mutation in polycythemia vera, and it is associated mainly JAK2 V617P is the most common one, and it is associated with 90 to 95% of the population. Whereas following it, if it is absent, exon 12 mutation is seen in the rest of the population. Okay, so erythropoietin low, and we need to confirm the JAK2 mutation. Now, what are the causes of the high erythropoietin? So high erythropoietin causes APO high can be due to two reasons, either hypoxia or hypercarbia associated, or it can be due to some malignancy or mass that is leading to the secretion of the erythropoietin. So malignancy or mass related. All right. So to how to go forward, hypoxia will be seen in cases of if there is any intracardiac shunt patient, as in case of cyanotic congenital heart diseases, or there is lung pathology like chronic obstructive lung diseases, there is intracardiac shunt, or hypercarbia is usually seen in chronic smokers, or it can be seen in someone who dwells in tunnel dwellers, or working in the gasoline factories. All right. Okay. So among malignancy, which one are the important ones which is associated with increase in the erythropoietin level? The one which are associated with increase in erythropoietin level are hepatoblastoma, renal cell carcinoma, cerebellar hemangioma, and leiomyomia. Okay, so let's get back to the chart of the Harrison. So what was it mentioned? So once erythropoietin level are measured, and if it is elevated, so what is the next step? An approach involves. Next step and approach involved to check for the arterial oxygen level. If arterial oxygen level is high or that is normal in range, that means hypoxia is ruled out. So we are checking it for check for the hypoxia. So hypoxia, that is diagnostic evolution for heart and lung diseases. It can be COPD, high altitude associated hypoxia, intracardiac shunt, that is cyanotic heart diseases. Now if it is normal, check whether smoking history is present or not, and if smoking history is present, measure the carboxy hemoglobin level. If carboxy hemoglobin level is coming to be elevated, you can label the person to be smoker's polycythemia. All right. Now if there is no history of smoking, or the patient is smoking but carboxy hemoglobin level is normal, check for the hemoglobin oxygen affinity, and if it is increased, it is oxygen affinity hemoglobinopathy, whereas if it is normal, you need to search for the tumor source. Now this Harrison chart is wonderful to understand the pathogenesis, but does it help really in practicality? It doesn't help, as 51 chromium level RBC is a very costly test and is not available everywhere, and there are a lot of pathology which you can identify just from the history itself. For example, you can take the history of COPD, you can take the history of smoking, you can take history of intracardiac shunt or other method, check the personal history of high altitude. Similarly, diagnosis of relative erythropoiesis should not be wasted using 50 chromium RBC test checking the radioactivity. It can be taken simply from the history of whether dehydration, sign and symptom of dehydration present or not, or the patient is taking any diuretic therapy or not. All right. Okay. So how to go practically if a SAMNI patient? First of all, we need to identify what are the red flags here in this diagnosis. Red flag are those which are associated with malignancy. So if there is no history of any relative erythrocytosis or no history suggestive of any lung pathology or cardiac pathology or smoking, obviously in such cases you need to think about a secondary source of erythrocytosis or polycythemia. Check APO level. If it is low, consider it to be polycythemia vera. If it is high and all the history points are ruled out, search for malignancy. What you need to do to search for malignancy? USG abdomen to look for renal cell carcinoma as well as renal cyst. Leiomyoma can also be detected with USG abdomen and hepatoblastoma, and CT head to check for cerebellar hemangioma. Okay, so how the patient will usually present? Patient will usually present in asymptomatic state or experience symptom based due to increase in the red cell mass. Beside that, symptom can be due to the secondary causes which causes this this erythrocytosis. For example, symptom can be due to the malignancy related, symptom can be due to the lung pathology, there can be history of breathlessness, there can be difficulty climbing stair present in the patient. So these are all the symptoms that present, that is directly due to increased red cell mass or due to the pathology which it is causing. So what will be the symptom due to increase in the red cell mass? The dominant symptom from its increased red cell mass are related to its hyper viscosity nature, and also nature to form thrombosis, both arterial and venous thrombosis. Remember, in polycythemia, not only single line, in bone marrow aspiration as well as biopsy, tri-lineage cell will increase, and therefore there is increase of the platelet count also. And if platelet count is severely high, more than 15 lakh in a person, there is consumption of bone involvement disease. Due to this consumption of acquired bone involvement disease, bone involvement factor consumption, there will be risks of bleeding in the patient, which may present as epistaxis, peptic ulcer disease. These are very much common. Due to the thrombosis, there can be cases of digital ischemia, or Barchieri syndrome, or hepatic or splenic vein thrombosis. Okay. Now, if the patient was cyanotic, there can be mainly due to hypoxemia related. There can be cyanosis on minimal exertion. They can have headache, impaired mental acuity, or fatigue. There can be as well as symptom of pruritus, and these pruritus are usually managed by antihistaminic medication. And neurological symptom can be there vertigo, tinnitus, headache, and visual disturbances. And hypertension are usually present at the onset of diagnosis. Okay, so these are the feature that they comes with to our places. Okay, so coming to the question, serum erythropoietin level are elevated in all except, so it is increased in hepatocellular carcinoma, renal cell carcinoma, cerebellar hemangioblastoma. So answer here is pancreatic carcinoma. Secondary polycythemia may be seen in, it is seen due to mainly either increased erythropoietin level. So erythropoietin may be due to malignancy related, or due to hypoxia or hypercarbia. Which of the following diseases is associated with hypoxia? Cor pulmonale is associated with hypoxia. Okay. Which of the following is not part of the diagnostic criteria of polycythemia? Now, what is the diagnostic criteria of polycythemia, guys? So remember what we are saying from the very start. A patient comes to us with raised of the hemoglobin or raised hematocrit. This is the first major criteria for diagnosis. Second thing, in such cases, often malignancy or sort out, because these are the close differential diagnosis of such raised count. So bone marrow biopsy are invariably done in such cases, which will show increase in the marrow hypercellularity, tri-lineage increase, as well as megakaryocytes. Then we have discussed about the specific mutation, that is JAK2 mutation is seen. These are the major criteria. Beside this, we have a minor criteria. Minor criteria is erythropoietin level to be normal. Okay. So these are major and minor criteria. It is usually diagnosed between two major. We have the first two major along with one minor, or all of the three major criteria. So hemoglobin more than 16.5 gram per dl in male, yes, it is the part of the diagnostic criteria. Presence of JAK2 mutation is part of the diagnostic criteria. Normal serum EPO is part of diagnostic criteria. Bone marrow showing hypercellularity, no, it shows hypercellularity. Okay, so here this is 2017 diagnostic criteria. We have hemoglobin more than 16 for men, 16 for women, 16 point men, 16 in women. Hematocrit more than 49 in men or 48 in women, or increase in red cell mass. Now, bone marrow biopsy is showing hypercellularity. with trilineage growth, including prominent erythroid, granulocyte, and megagrocyte proliferation with pleomorphic mature megagrocyte, and presence of JAK2 V6175 or JAK2 exon mutation. Now, what is meant by V6175? V is for valine, F for phenylalanine. So, valine to phenylalanine mutation. Now, minor criteria involve serum APO level less than the reference range for normal. Okay. So, once we have diagnosed it, now let's come to the treatment part. So, how to treat the patient, guys? Okay. So, how to treat the patient? So, we need to differentiate the patient between whether this is a low risk patient or a high risk patient. So, whom do we consider low risk patient? Any young patient, easily less than 60 years of age, and there is no history of thrombosis, no thrombosis, and platelet count in less than 15 lakh. Why 15 lakh is taken as a parameter in this cutoff? Because more than 15 lakh there is chance of consumption of van Wallman factor resulting into acute van Wallman disease. So these are considered as the low risk category. And how do we treat the patient? We treat the patient with phlebotomy to maintain. Phlebotomy is done to maintain the hematocrit less than 45% as a target, and along with aspirin. All right, you need to give the antiplatelet to the patient. Now aspirin should be used cautiously if platelet count is more than 15 lakh or there is or with extreme thrombocytosis or acquired von Willebrand syndrome. Okay. Now there are symptoms of severe pruritus. For severe pruritus, we need to give antihistaminic. Remember, on clinical finding, this patient might have splenomegaly. Hepatosplenomegaly will be there as there is increase in the red cell number that needs to be destroyed somewhere in the body. So spleen, as a reactionary, there will be increase in the spleen size. So if there is severe abdominal heaviness or pain in the spleen during lysis of the cell, so if there is painful splenomegaly, or the pruritus is not responding to the antihistaminic, in such cases we need to go for the second drug to control the platelet count, that is hydroxyurea. Now, depending on the toxicity to the hydroxyurea, we can also choose for the specific, which is for this condition only, is ruxolitinib. Usually started as 10 milligram BD dose, and dose is titrated depending on the response. Now, in a patient with history of prior thrombosis or bleeding due to acquired von Willebrand syndrome, or normalization of platelet number becomes very much necessary. And if platelet control is inadequate or the patient cannot tolerate this medication, other thing needs to be need, like supplementary phlebotomy is required to maintain this, as well as hydroxyurea needs to be continued in such patient. Okay. Now, if a patient is high risk is, for example, age of there is age more than 70 years, or there is risk of severe thrombosis is present, or the drugs that we are giving to the patient is contraindicated. In such cases we need to go for busulfan. Okay. And if there is severe painful splenomegaly, splenectomy can also be done. Okay. This is about the treatment part of the polycythemia.